Thank you, Dr. Jyoti. Uh, this is a very important talk because when Jyoti gave me this talk, I started reading and I found that I didn't know a lot of things. What is resistance and what is non-responders and all this stuff. So I will go back to that. We have a good number of therapeutic armamentarium starting from Avastin to Vabysmo over the last 15 years, 20 years. And the problem is all the drugs will not work for every person. And a subset of patients respond very poorly to some drugs and they don't respond to some other drugs better. It is there in 20 to 40% in neovascular IMD and 15-20% diabetic retinopathy. So it is what is resistance to anti-VEGF? It may be a poor visual response. In spite of you giving, patient is not improving in vision less than 5 letters of improvement. And it may be a poor anatomic response. Oh, no, OCT, the biomarkers, they are not improving. But there are no recognized definition for this. So, there is a biological basis for this resistance. Why? Because the VEGF is not the only factor that can cause resistance. There are other pathways, PDGF, angiopoietin, a lot of other inflammation. All these pathways are there. That is why when you give some injections, it is not responding. So I took this article, How to Judge Failure, Defining Treatment Resistance to Anti-VEGF, a systematic scoping review. They took all the 400 studies and the 88 studies which met the criteria were taken. And in neovascular IMD, since this is on neovascular IMD, one mistake that many people make while telling it is resistance is due to wrong diagnosis. Some may be CSR, some may be PCN, some may be PCV, and some may be wet AMD. So the wrong diagnosis is one of the cause for so-called resistance, and various masquerades can cause resistance. Then duration of intensive prior treatment is very important. You can't give one injection and after that there is no improvement, say this is resistant to that. Okay, so the consensus based on this study was that the duration of intensive prior treatment required to define resistance was at least 6 months. Different studies showed 12 months, 8 months, like that. But at least there should be a 6 months gap, 6 months of intensive treatment with at least 4 injections in 6 months. Then only you can call it resistance. Then the biomarkers in OCT like subretinal fluid, intraretinal fluid, and some cases they used the PED and SHRM, which were also used. And some studies used visual acuity guidelines, less than 5-letter improvement over 6 months. So the criteria for defining treatment resistant neovascular AMD is one, presence of SRF and or IRF in OCT. You can use worsening PED and other things also. Despite regular therapy, less than 6 weekly injections for over 6 months. That means at least 4 injections in 6 months. Although intensity of monthly dosing regimen has been used in many studies, a significant lot of studies they didn't have this 6-month duration to define resistance. Just one slide on DME, because we are all treating DME. There are 2 other factors in DME, because DME has inflammation as a pathology, and they use something called central macular thickness for defining resistance. So in DME, the resistance is if the central macular thickness is more than 300 microns or less than 10% reduction in CMT despite minimum 3 anti-VEGF injection. That is resistance in DME. Okay, so these 2 definitions you should be very careful. You should know. So 6 months. DME, you can call it resistance after 3 injections for 4 months. Okay. Neovascular AMD, you call it resistance if you have at least 4 injections in 6 months. What are the mechanisms? Different types of mechanisms are there. Alternative angiogenic pathways, receptor desensitization, even systemic problems. So you can predict anti-VEGF resistance based on imaging biomarkers like PED, intraretinal fluid, hyperreflective dots, ELM integrity, all these things. And molecular biomarkers are used, especially cytokine signatures, which are being used in different research. predicting anti-VEGF resistance based on genetic and epigenetic predictors is another complicated issue. I don't know anything about this. But systemic and metabolic biomarkers like HbA1c variability and serum albumin and renal function are important in many cases, especially in diabetic macular edema. So this is predict biomarker OCT, inflammatory, angiogenic, genetic, and metabolic. So these are the things that predict anti-VEGF resistance. So like this, this is a case. Injection was given 9 injections over 6 weeks interval. Then it was changed to aflibercept, 12 aflibercept, 8 weekly interval. Then it was changed to faricimab. In spite of faricimab, it was worsening continuously. You can see in spite of injections. And then after 5-6 weekly intervals of faricimab, it was converted back to aflibercept. This is a real resistant cases after 14. So what do you do when you inject and there is no effect? You have to change the dosing. You can shorten the treatment interval to 2 weeks, which is very difficult. As such, we are trying to reduce the injection. Now you inject every 2 weeks is going to be very difficult. So the second one is use higher dose. This is coming with aflibercept high dose. It's coming. So that may be a good option for nAMD. Then switching the anti-VEGF agent is definitely an option, especially some of the H2 or PAGF in aflibercept. So switching the drug using another pathway will help in many cases. Treatment option 3 is one that we use many times, laser or steroid injections in some cases, focal laser, photodynamic therapy. These things can work in many cases. So this is a case of PCV, not neovascular AMD. So this is after 3 injections, nothing is happening. Then this is a bunch of polyp and forced full fluence VDT in 2015. It became flat. To some extent, it stayed for 2 years and it again came back. And there were new bunches of polyps. And again, PDT was repeated. Again, after 2 years, it started coming back again. So we are not telling that it is going to end the story, but definitely the number of injections can be reduced. So key takeaways are shortening the treatment interval, not very useful. Increasing anti-VEGF dose, maybe. Switching anti-VEGF agent, definitely. And combining with the other therapies like laser and some drops. So what is the future? Tailored therapy is the future, where if the patient's inflammatory profile and fluid analysis may be done along with the initial thing, and some of them will have preference of some VEGF pathway or ANG2 pathway or something. And later, probably some patient may be ideal candidate for PDS or gene therapy. So these are the things that I just want to highlight about anti-VEGF resistance and management. Thank you.
Thank you, sir. Thank you,
Any
sir.
question?
Any questions from the audience?
I have to, yeah.
Actually, very good presentation. What I would like to add is that in patients not responding to anti-VEGF, I think there is a role for wide field ICG angiography because many of these patients have got vortex vein abnormalities. And that is the reason why the VEGF is not acting. So there is still a role because today we are managing all patients with OCT. So there is still a role for these sort of investigations in certain specific cases. And that should be kept in mind.
Absolutely. Not only wide field angiogram, FFA ICG has a role because many times you will see a feeder vessel or a small polyp or something like that, which will help to give focal laser to that, which will totally then anti-VEGF injection may not be required. So even angio, ICG, and wide field are very useful in the multimodal imaging in neovascular AMD treatment.
Yeah, I heard of antibiotic resistance. The first time I'm hearing about it. We never thought. Good presentation. These are protein molecules.
It's a protein.
Protein molecule. So naturally the body will produce antibodies for it. So switching is one option. Giving steroid may be another option to suppress the. But the point here, if once it gets resistance, the more the same drug you give, there will be more inflammation. Because again, but that is why you see those spikes still, the fluid collecting there.
Yeah. Right.
Okay. Triggering.
So thank you, sir, for